The studies done in the Harvard Medical Practice Study and repeated in 10 other countries show that about 6.6 of hospital admissions are associated with adverse events. 8% of these result in death. Half of them are preventable. You get similar results throughout other places. And if you apply that figure to England or England, Wales, UK, you get about 25,000 deaths as a result of avoid events in England every year. The MPSA, I think, finds about 900 of those, picks up. And so that probably picks up only a small proportion of them. The question of looking at the effectiveness of stopping infections sort of was brought out clearly by Semmelweis, as you must all know probably, in Vienna in 1847, when he noticed that the medical students and the doctors were examining during vaginal examinations and not washing their hands afterwards. And the ward that they went to, they had a very high mortality rate. And in the nurses' wards, they had a much lower, and they tended to wash their hands. This was before the era of plastic gloves. And so he tried the introduction of chlorine hand washes. And these are the figures which I copied actually from Wikipedia, showing that there was a very large reduction in mortality, in perinatal mortality and in infections, presumably mainly strep infections, as a result of the introduction of chlorine hand washes. He tried to get this information around Vienna and later on in Prague. They all thought he was mad. He was put into a mental asylum, actually with the agreement of his wife. He was beaten when he went in and died 2 weeks later of an infection from his wounds. We've got a sort of we've had a wide variation of MRSA resistant bugs. One of the highest in this map here. And if this is the trends of MRSA resistance, and we are the countries in Europe as recorded by the European antimicrobial resistance surveillance system, and we are here, and at that time we were increasing. Another study gives similar results, and United Kingdom is here. So we didn't do particularly well. These are death certificates. As you know, death certificates, the requirement of recording if a death was related to healthcare-acquired infection, and it had to be either a death which was mentioned as resulting, this is the C. diff data, or was an underlying cause. So the underlying causes were the black bars, and any mentions were the green. So roughly the underlying cause is about half of the top. And you can see that with the introduction of the hand washing campaigns, there wasn't really actually initially very much change until money was put in to I think it was £50 million, and then there was a large reduction. There was the deep clean. And I was working at that time in the Institute of Healthcare Improvement in Boston with Don Berwick and Maureen Bissignano. I was in the room with them and with some Dutch people. And when the deep clean was announced, which was going to be done once, I remember the Dutch sort of almost falling on the floor with laughter that it was going to be done once in the NHS, whereas they said they were required to do a deep clean every month. These are the figures for the increase, the numbers of death certificates. But these are the mentions, not the total deaths. And the blue are MRSA, and the green is C. diff. And that's the similar data which I've just shown you. This is the C. diff data. and this is the MRSA data. And here is the number of geriatric beds in England, and there was actually a leveling out at that point. So there was a reduction in geriatric beds. Now, the methods that we have of surveillance, and I've listed some of them, are the voluntary surveillance systems and then mandatory surveillance. As I've just mentioned, the Clean Your Hands campaign, the Deep Clean once, things which we've been associated with the Q-sum mortality alerts. That's the cumulative sums of deaths. And I'll show you a bit later how that works out. Also, the use of care bundles, surgical site infections, and so on. And I just wanted to mention at the end the possibility of remote video auditing. So this is just the uptakes, the increases of alcohol hand rub and soap combined, soap, just alcohol, and these increases as a result of these campaigns, and the numbers of C. diff infections, not massive change. These are just more recent data, right up to date, just showing similar sort of changes. This data is quite interesting in that I collected what is equivalent to the hospital episode statistics data for 7 countries. And the data of the 7, this is England and this is the United States. And for all of the countries, the figure is fixed at 100 for the year 2004. And you can see that the States is a bit below 100, and we are rather above 100. This is the SMR on the left-hand side, the standardized mortality ratio. But what you can see is that we've gone down at a rather more rapid rate than in the United States. And if you were to take the ratio, we would actually be doing much better than the States. So it looks as though we started off in 2004 having a rather high mortality, standardized mortality ratio, adjusted for everything that you can think of that has an effect. And similarly with the data in the States, using the same methodology. But we have actually gone down in relation to the States. Looking at ways you can actually collect the data, this is the data from what I've just mentioned, the hospital episode statistics. That's the data that's, from the PASS system, patient administration system in every hospital. Initially from 1961, there was HIPI, the Hospital Inpatient Inquiry, which was a 1 in 10 sample. And then in 1988, it became hospital episode statistics, which was a 100% sample. But as a result of the work of Baroness Kroner in the 70s and 80s, a lot of clinical data was added to the financial data in order that we could use what is collected in the patient administration system data, which is monthly, to start looking at quality of care, or at least adjusted death rates and other factors in hospitals. So this is just comparing the information that you can get from the Health Protection Agency, which is that bit there, and the data which is available in HES, Hospital Episode Statistics. And the thing is that they are fairly similar. This is actually adjusted death rates, and I chose this one because it's at the time of the notorious Maidstone and Tunbridge Wells Trust, which had high levels of C. diff, and led to really the first of the Healthcare Commission's main investigations of a trust. And you can see the measures would have shown actually earlier on that Maidstone was high compared with the others. The data actually produced in the Healthcare Commission report showed that they were at this particular time compared with the others. But one of the things that always struck me from that report was this photograph of the narrow spaces between the beds on Ward 8 in Kenton Sussex Hospital. I think it was the geriatric ward, they were very close together. And when you look at the reduction in beds, I gave you the figure for geriatric beds before, that's this one here. If you look at mental illness beds and learning difficulties, they've gone down enormously. Learning difficulties almost disappeared. And even acute beds have gone down. In fact, even in the last years, we actually now have the lowest, of the OECD 31 countries, we have the lowest level of acute beds per head of population, apart from Mexico. Mexico having a level which probably could hardly be accurate, have almost zero. I don't think they record it actually well. So we have been reducing beds. With the reduction of beds, of course, has come a concomitant increase of admissions, a reduction in lengths of stay, but an increase of costs, because the more admissions you have, the more initial costs with each admission. So my view is that this is being designed probably by management consultants rather than doctors in ending up with a more costly healthcare system. Now, how do we actually look at mortality? And one of the things that I was involved with was in 1999 to 2001, I was the medical member of the Bristol Royal Infirmary Inquiry into Paediatric Cardiac Surgery Deaths. And we decided afterwards that probably, or as I'll show later, the Department of Health accepted eventually that it was responsible, and we decided that it would probably never do anything about it. In fact, might even actively act to prevent anything being done about it, as far as we could see, as far as we could judge. And we therefore thought we should start a unit, which we called the Dr. Foster Unit, at Imperial College, to try to get alerts when particular hospitals had particular high death rates for certain diagnoses or procedures. And our motto was, Bristol should not occur again. So the way the mortality alert system works is, now this is just one I chose at random, more or less. It's for a particular trust I've taken the name off. It's looking for septicemia, and I chose it for septicemia, except in labour. And there are 227 spells, which is really admissions. A super spell is an admission that goes on to another hospital nearby within 2 days. Not much change here. The period of the admission is there. And you can see that in this instance, there were 89 deaths and about 26, actually there are 115 deaths, about 89 expected deaths, so about 26 more deaths than would have been expected by the national death rate. The way you can look at these slides is each little blip is one patient admission out of the 227. The graph goes up a lot if the patient had a low risk and dies. And this is the adjusted death rate after allowing for very many things. It goes up a little if the patient dies and has had a high risk, and it goes down the other way around. And so you'll get to a point where it's gone up, and it's reached a point where the numbers of deaths exceeds the number that would be expected, and the level of that, the chances of that being a false alarm are less than 1%. In fact, in this instance, 0.1%. So that the false alarm rate is 1 in 1,000. The chances of it being within the last month or 3 months being double the national death rate is likely to be, the alert is likely to be false in less than 1 in 1,000 cases. Now, this is nothing new. These are Q-sum charts. They've been used in the car industry at least since the 70s, where Deming went along and helped Toyota to improve the quality of their cars. When a clutch breaks, etc., all these things are signaled. The statistics of this were invented by Schuhart in 1928 and in the 1930s. This is continuous quality monitoring, which we've not done in healthcare. We had a presentation at the Bristol Inquiry when I was on the panel, and they suggested that we should do this, and we just basically took up the suggestion. These are points where there had been additional alerts, so the numbers going up all the time. And what happened was that we made these available to the people using the data, and we thought that probably they were not actually doing anything about it. When they logged on to the information, the trust would see their red bell mortality alert as the default screen, where the problems were in all the diagnoses. We decided this was starting in 2003, decided in 2006 that they were unlikely to necessarily take notice of it. They could see it, but they wouldn't necessarily take notice of it. So we decided, actually, in 2006, to send letters to the chief execs of trusts who had got alerts, which we implemented in 2007. They led to the mid-staffs inquiry, and the SHA that was dealing with mid-staffs, although it was stated that they had no mortality data, they'd actually logged on to the alerts and seen the red bells during the period of the inquiry, their organization 69,000 times. So this is another approach which I've been involved with a bit, which is using care bundles, which are basically summaries of those enormous piles of recommendations of good practice which come from NICE and so on, in a way, on a sheet of paper, which is stuck inside the notes. It was implemented mainly by Liz Robb, who was the chief nursing officer at North West London, mainly based at Northwick Park. And this records the details of the patient. This is a sticker that goes on the outside of the notes, a different color for each diagnosis. And she wrote to me before they started and said, could I tell them the diagnoses that led to most deaths? So they developed 8 lots of care bundles, which covered the majority of the deaths. And from the 1st of April 2007, implemented the care bundle system under the strong arm direction of Liz Robb, and I can assure you it's a very strong arm direction. And this is another example of a surgical site infection care bundle. What it means is that sort of the clinician getting up in the middle of the night and saying, oh God, here's a patient, so-and-so diagnosis, what do I do? There is the thing that they have to do, and they have to sign that they've done it. And we also monitored mortality rates. Now, just to show how they work, this is how you would adjust for age. So this is the age groups. This is the national death rate. This is the number of admissions in the trust per year, or hospital. If you multiply the two together, this is the numbers per 10,000. You've got a figure here of 1,000 times 1,000 per 10,000, which equals 100. And that's the number of deaths here, 100. So you basically multiply the national death rate by the number of admissions by age group and get the number of expected deaths. Then you add them up all the way across the age groups, and then you do it by age and sex and emergency, and age, sex, emergency diagnosis, and by all of the variables that you put in the regression analysis, the logistic regression analysis, which could be of cells, about 80,000 per hospital per year. And they monitor, now upwards in this graph is good, rather than red being bad. And they monitored HSMRs over that year, and within about 3 months, from being, and the stimulus for Liz Robb, by the way, was that they had a problem in 2000, and I think it was 4 or 5. They'd actually had some deaths in maternity, and also some young men died of organ failure. And she went over to IHI and learned about care bundles, implemented them in their HSMR, this is monitoring by individual patient. This is the number of patients that have been monitored, 50,000 patients. And the previous year, there was no change, and then there was a very dramatic change as soon as they introduced the system. And the HSMRs went down in that particular year. But this was the high year when they were high in 2004-05. And they have remained significantly below the national figure of 100 since then. This last figure here is for 2012-13, it's not been rebased, which we don't do until November. So it may go up slightly later. And if you look at it in terms of funnel plots, this is the 99.8% confidence limit, and this is the 95%. So anything is above there, there's less than 1 in 1,000 chance that it is a random variation. And these are the trusts in England. And in 2000, the preceding year, Northwest London was there, and after this, they dropped to there, which was the lowest HSMR in England, by introducing that. And I think it's one of the few non-university teaching hospitals that has been the lowest HSMR in England. The actual numbers of deaths, expected deaths, because the case mix is similar, has stayed about there, and then it has, the number of observed minus expected is about 600 per year now, from 0. And then the remote video auditing is a system of actually auditing, remotely from anywhere in the world, but done in, I think, Houston, Texas, and India, watching what is going on with hand washing and various other things. The data here I've got is from Long Island, which are hospitals in New York area. And they thought that they had a level of hand washing of 60%. Now, these are daily counts. When they monitored it, their figure was around about 30%. But within a couple of weeks, they went up to around 85, 90%, and have remained at that level for 3 years and are still at that level. This is monitoring. Of course, you can monitor various other things remotely. Now, I've got a number of other slides, but I think I can see the chairman asking me to stop. Or is that not the case? Sorry? Shall I go through them quickly? Okay. Okay. Make it 5. I'll bargain with you. Okay. So, I mean, really the question is, why haven't we been doing these things? And I think there's been a Virchow effect. Virchow says medicine's a social science and politics nothing but medicine on a grand scale. Ian Kennedy, chairman of the Bristol Inquiry, said, I have doubts that we will ever succeed to do anything effective, while the health service is exposed to such political winds. In France, they follow it backwards to make sure there are no political involvement in the health service. The monitoring systems we have are enormous, are meant to be monitoring quality of care. But our conclusion at Bristol was there was confusion. Department of Health accepted in the end it was responsible for doing it. We thought they would never do it. The person who was in charge of all that was given by the whistleblower, Steve Bolson, a thick envelope after a couple of years trying to get there. We asked this man, doctor, what did you do with the envelope? He said, I put it on the shelf and didn't open it. Our conclusion was he didn't know what to do with it. And our other conclusion was, effectively, it will happen again. And the thing that impressed me and sort of got me to get this unit formed was that there were major problems at Bristol. They didn't even have a pediatric cardiac surgeon, but it was an adult surgeon doing it. And the mortality dropped from 29% to 3% once they corrected those things within 3 years. It just dropped down like that. I thought the parents of those kids who'd been brought in to have their operations should have been told they could have driven an hour up the motorway, got a mortality of 6%. So, what happened? There are all of these various things which were not working, but I would just like to ask the audience one thing. Which organization, when the Mid-Staffs inquiry came out in February this year, which organization, could anyone tell me, is responsible for monitoring quality of care and safety in the NHS? Does anyone know? What, sorry? Health and Safety Executive, very good, because its name is Health and Safety Executive, looking at quality of care. Any other advances? Well, Health and Safety Executive has said it does not look at clinical care. It has just done its first case, and yesterday, Gillian Asbury at Mid-Staffs, who is young, diabetic, insulin dependent, who was not given her insulin for 6 days and died in mid-staffs. And the trust has now admitted it was completely wrong. And it's going to go to the High Court. The HSE does not investigate clinical care. So who invests the quality of clinical care? Does anyone like to say? CQC, very good, very, very good. Does the CQC? Its statement is, CQC registers health and social care organizations and corrects non-compliance with its 16 essential standards, which are things like respect, and they specifically say not paying attention much to mortality. It states it does not investigate possible incidents of clinical care or clinical quality. We have, at least when the report came out in February, we had no monitoring of clinical care in our hospitals. None. And Francis said that himself, and his conclusion was, this has led to a regulatory gap which needs to be closed. Page 60 of the Francis final report. I think that is the understatement of the 1,800-page report. And there were reports which were suppressed by 3 American things which drew attention to the major problems in the NHS. And the chairman of the 3 regulators all effectively said just to the culture of the NHS, particularly the hospital sector, I would say is not to embarrass the minister. Virchow speaking again. The minister said, the impression of all of us was that we would just, constantly do what was meant to be the thing that number 10 wanted, or that we were all, unthinkingly piling this through. We weren't, and gave 2 examples to prove the rule. And I think the chairman is getting a little bit worried, so I'll finish. The last slide, which I got through very quickly, basically is a slide of optimism. I think the changes that have been taken place since the report came out in February to inspect the high death rate hospitals, to have a chief inspector of hospitals, and the changes at the CQC, all of the board changing virtually, are very positive. So I actually, at the moment, am in a positive mood about changes. Thank you.